Good afternoon and welcome to the Center for Optimizing Rural Health's monthly webinar. I would like to begin with a couple of exciting announcements. We're about to begin our second year of the Vulnerable Rural Hospital Assistance Program, HRSA funded grant, and with that we will be opening the application portal to new applicants. The application portal will be open September the 3rd through October the 31st. We invite you to go to our website and take a look at the exclusion and inclusion criteria for this grant, and starting on September the 3rd, hopefully apply for technical assistance. Our website is www.optimizingruralhealth.org. We'll also send a link out after this webinar in an email, and on August the 26th, we will also be hosting an informative webinar on the services that the program offers and guidance on the application process. So now that we've got those announcements out of the way, I would like to introduce to you Dr. Murray Cote. Dr. Cote will be speaking on the topic of patient safety today. Dr. Cote is an associate professor and director of the Master of Health Administration program in the Department of Health Policy and Management at Texas A&M University in the Health Science Center. His research interests are in the application of industrial engineering principles and tools to improve the delivery of healthcare quality. Dr. Cote's research has been published in Hospital Topics, Journal of Elder Abuse and Neglect, and Operations Research for Healthcare, among many others. So we're very honored to have him with us today, and with that, I will turn it over to you, Dr. Cote.
Thank you, Cassidy, and welcome everyone. Good afternoon. I'm Murray Cote and faculty in the Department of Health Policy and Management at the School of Public Health, and I'm very honored to be here to share with you what we've titled a primer on patient safety. First of which, of course, we have our standard disclaimer. This webinar is supported by the Health Resources and Service Administration, HRSA, of the U.S. Department of Health and Human Services, HHS, under the cooperative agreement U2BRH32163. And of course, the contents are those of the author, not authors, it's just me, and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. All right, so without further ado, thinking about this in terms of a presentation opportunity to share some general ideas about patient safety. For this afternoon, what I'd like to talk about, we'll talk a little bit about AIRS. We'll talk a little bit about defining quality. I think the Institute of Medicine is a crucially important organization, so I want to share with you a little bit about that, especially in the context of learning about other resources. Pulling on my background as in engineering, it behooves us to chat a little bit about systems thinking and processes. We'll go then right into patient safety and then conclude with what I think is one of the most appropriate approaches to trying to improve patient safety is failure modes and effect analysis as one of our important tools, and then with some guidelines for designing safe processes. And of course, if time permits, we'll have opportunities for questions. All right, so first thing, some very important icons. You get a sense of what's going on. If we want to improve a process and if we want to help people understand what they ought to do, okay? And these are icons that have been with us for decades. We look at them and we see them and we say, oh, right away we know who Smokey the Bear is. We know what he tells us to do, okay? We know, and we teach our children very early on to stop, drop, and roll, okay? Thanks to Ralph Nader in the 1960s, we have seatbelts, and we know that seatbelts save lives, okay? For the historians in the audience, okay, at around the time of World War II, when we were trying to protect the country, protect our secret, we of course said loose lips sink ships. Okay, so that's a starting point. Now, if we think about this in terms of all of these are geared towards making us safe, making our forests safe, making our campers safe, making our kids safe, making transportation safe, making our country safe. Okay, so we think about this then in terms of how we make healthcare safe, or how we want to make healthcare safe. And so I'm going to go to what oftentimes becomes arguments about, are we number one? Are we number one? And Gapminder, approximately 4 years ago, came out with this wonderful graphic that illustrates life expectancy, and that's on the vertical axis. That's in the very big text that says health, and they're using life expectancy as a proxy for health. And on the horizontal axis, they talk about income, and income ranges from poor to wealthy nations. And then the little icons inside, I love the graphic for what it serves, the purposes that it serves. The graphics are color keyed, so based upon where the country is within the world, so if it's blue, it's in Africa, if it's red, it's in Asia, if it's green, it's the Americas, and if it's yellow, it's Europe and part of Russia. So when we look on this map, what we see is, generally that nice relationship as the country gets wealthier, they get healthier with it, which is nice. And I think that's an important component, especially for us who study health services research and work within the context of public health. If you look in the upper left-hand corner and you focus on, and I apologize if you're colorblind, but the pimento olive in the upper right-hand corner rather, is the green part is the United States. So we're pretty wealthy and we're pretty healthy, but we're not number one with it. There are countries who are slightly wealthier than us and have higher longevity, and there are countries that aren't as wealthy as us and also have higher longevity. And this becomes a perennial challenge when we talk about health policy. How much should we spend on healthcare? What's the right amount to spend on healthcare? And are we getting value for our healthcare? And so put ourselves in context is we're good. We're not great. We're not number one, but we're good in terms of wealth and in terms of health. Now, behind that, when we look at the practice of health, and one of the first places I take people to is, well, tell me part of the Hippocratic Oath. And the first thing that people will say, and they'll misquote it, they'll say, first, do no harm. And that's not part of the Hippocratic Oath. In fact, it says, for physicians, abstain from all intentional wrongdoing and harm. And I think that's appropriate, especially as we look at patient safety. We never enter into this practice and say, yep, I'm going to hurt the patients deliberately or unintentionally. We're not going to do that. We don't want to do that. That's part of the nature. We're going to prolong life. We're going to remedy illness. We're going to make people healthier after our care. I think that's our intention, and it's a very noble intention. Now, when we look at healthcare as an industry, this is perplexing for us, especially for those, again, who study health services research and who work within public health. So I'm going to go back 6 years ago to the Boeing 787 Dreamliner, absolutely spectacular plane. If you get a chance to fly on one of these, I mean, it's stunning, the technology that is available. But very early in January of 2013, the 50 aircraft that Boeing had built at the time, they had problems with their lithium-ion batteries. And in fact, they said there's a potential that it would cause fires, and we're not sure when the fires would occur. And the Federal Aviation Administration said, that's it, they're all grounded. We stopped flying them. And for approximately 3 months, they stopped flying the Dreamliners. And they said, we can't do this because there's too much of a potential risk to the general population. We can't have this. So the FAA stepped in and said, you got to fix it. And Boeing went back and they fixed it. Okay, we don't have that equivalency in healthcare. The nearest part of it came out approximately 20 years ago. It was published by the Institute of Medicine, and this started a whole series of us from a national perspective looking at how we make healthcare better. How should we improve healthcare for the 21st century? And the Institute of Medicine started, and they essentially drew a line in the sand, and they said, to err is human. You know, we have this amazingly complex system in place that provides healthcare to everybody in the country, and we're good, we're not great, and we make mistakes. And the mistakes here that they came up with was a statistic, it was an estimate that they said somewhere between 44,000 and 98,000 deaths can be attributable to preventable medical errors with it. And I put oft-quoted and misquoted, depending upon your context. These statistics aren't necessarily taken in the vein that they were intended to, okay? Now, putting the statistics, this estimate in perspective, what essentially the Institute of Medicine said is that, this is somewhere between about 160 and 350 fully loaded 787 Dreamliners crashing annually. And we do nothing. Boeing has problems with their batteries, and we stop it from flying for 3 months. But if this is truly a statistic that happens in health services delivery, we don't see this kind of amazing, dramatic action that happens with it. And that's a big, big number. Now, Institute of Medicine said, we got to be better. We got to be better. And they pushed for recommendations to make health systems safer and more appropriate in the delivery of health care. It took a little while, but the Office of the Inspector General, that's the OIG, back in 2012, talked about how hospitals can report patient harm. And what they found, unfortunately, is that most systems, most hospital-based information systems, aren't set up to capture patient harm. It's just something we don't record and not something that's not intrinsic to what we did. And there's a wonderful link there on Vox.com about medical errors and the potential that medical errors can have in terms of harming or killing people across the United States. And I would encourage, after the webinar, if you have a chance, just to review that. It's a wonderful short little video, okay? Now, when we talk about it and we set up policies and we set up trainings and you think, well, this thing, we should be good at this. We should be good at this. But in fact, just last week, okay, reported in Becker's Health, wrong site kidney surgery was a mistake. Well, yeah, it's a mistake. It's a patient error. I mean, they messed up. And this was done at Vanderbilt, which is a very, very reputable healthcare system, and yet these things happen. So still here in 2019, despite the technology, despite the training, despite the attention, we still make these mistakes. And interestingly, in the context of this article, one of the challenges that came back was they said, well, one of our pieces of technology wasn't working appropriately. The whiteboard that told us more about the patient wasn't working appropriately. Technology aside, we shouldn't be making mistakes, okay? And forcing it on technology rather than the people providing the care, providing the services, is a crutch with it. They looked for they said, look for the technology, and they said, oh, it was this. And I don't believe that. People ought to be trained. People in the delivery of the care ought to be trained that even if the technology is not there, we can still do the right thing. Okay. So, well, that leads us to an important thing, is that, we want to improve care. One of the ways of improving care is making it safe for patients. So in the context of healthcare, one of the things that we've been challenged with for decades is, well, how do you define quality? Okay. So if we go to Google and we say, give me a definition of quality, they're going to come back and they're going to say, the most common one will say, quality is meeting or exceeding your customer's expectations. Okay. This is nice, and we see it marketing. You'll probably find a plumber out there or an electrician out there, and their van will have something like that on the side as a logo, that they're meeting or exceeding customers' expectation. That's our goal every day. The challenge here, though, is really twofold. You got to understand your customers' expectations. What do they want from you? What do the patients want from you? I think in the context of healthcare, it's pretty easy. I want to be healthier, and I don't want the wrong thing done to me. Okay. And then the second piece is, how do you measure this meeting or exceeding piece with it? And that's been a challenge for healthcare since the 1960s, since we first started talking about quality of care. Okay. And the Institute of Medicine, I think, took this the appropriate direction. So following To Err Is Human, they came out with Crossing the Quality Chasm, and this is their definition of healthcare quality: the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. I thought that was ideal. If we want to improve healthcare quality, that's the approach we ought to take. Now, the Institute of Medicine has a series of reports. As I mentioned at the outset, we had To Err Is Human in 1999, and this is where they set the stage. And they said, we can make the healthcare system better. We can make healthcare delivery in the United States better. And they came up a couple of years later with Crossing the Quality Chasm. And this is where they addressed, how do we make healthcare better? How should we make healthcare better? And this has been guiding health policy for almost 2 decades. Indirectly or directly, we will reference Crossing the Quality Chasm because it's so important. And then subsequent reports for this, Keeping Patients Safe, Transforming the Work Environment of Nurses, looked at a smaller subset of health services delivery, notably nurses. So, for example, back in the early 2000s when the state of California was talking about nurse-to-patient ratios and mandating a certain number of patients per nurse to ensure safety of the patients. In part, it was precipitated based upon that report with it. Back in 2004, so 15 years ago, the Institute of Medicine was still talking about patient safety and saying, this is important to us. This is imperative that we do this. And they said, well, where do we learn? How do we make things better? Because we've kind of been not really stumbling along, but where can we borrow from? And we have industries out there that have been doing this for years, and in particular, the discipline of engineering, which was the 2005 report that said, engineering, it's ingrained in the way we do things. Why can't we borrow the best principles of engineering? Because we have systems, we have processes that we do, and we want to make it better, so why don't we borrow from them? And that was the essence of that report. What that led to was the idea of performance measurement. So how do we know we're getting better? Okay? How do we know, if you will, in the definitions, how do we know we're meeting or exceeding patient expectations? Okay? So they talked about performance measurement. A sidebar came out in 2006 where they said, related to getting our health system better is getting people to use the health system appropriately. So the 2006 report, Emergency Medical Services at the Crossroads, really tried to address the inappropriate use of emergency departments with it. And we're still working on that, still trying to get patients to understand what's an appropriate use of an emergency department versus what's an inappropriate use of the emergency department. And part of that has given rise to the standalone emergency departments or the standalone urgent care centers that have popped up across Texas. And we still see reports of patients visiting these places thinking that they're emergency departments and thinking that their payers will cover their visit with it. So we still have a ways to go. Building on the patient safety, talked about the second last report, the preventing the medication errors. And they said, well, not only is, should we not do the right surgery, we should not do an inappropriate surgery, but we should also do and be very cognizant of medication errors with it. If you've seen physician handwriting, this can be a challenge. And so this begat the use of technology and said, could we do this as computerized physician order entry and have pictures in there and appropriate descriptions of what medications ought to look like so we can reduce errors even further? And so again, this is that next piece of it. The most recent report, and this is not the be-all and end-all of their series, was finishing the loop, if you will, about lowering costs and improving outcomes. So if you do the right thing in terms of health services delivery and you provide the right care at the right time, at the right place for the right person, ideally, you will incur less cost in the delivery of care, and it will result in better outcomes for the patient and for the health system. So that's where the Institute of Medicine is, and I encourage you, if you have a chance, visit the IOM website and follow on their reports. And most of the reports are free to download. They come available as Adobe Portable Document File features, and they're absolutely wonderful reads with it. Now, building on these IOM reports, and again, talking in the context of patient safety. So what the Institute of Medicine did is they said, all right, here's our goals. And they put forward 6 goals for the health system for the 21st century. And so we're we're a fifth of the way through the 21st century here. They said, make it safe, okay? So go back to the Hippocratic Oath, okay? Avoiding injuries to patients from the care that is intended to help them, okay? They said, first and foremost, let's do what medicine is intended to do. Make it safe, okay? Make it effective. And this, you can see this is a very direct connection to the Institute of Medicine's definition of healthcare quality. Make it effective. So not anecdotal. You want it scientifically based. You want it evidence-based. And behind there's a little bit of an economic undercurrent that says, avoid underuse and avoid overuse. So it's kind of Goldilocks, if you will. It's not too cold. It's not too hot. It's just right, okay? But with no one being eaten by bears along the way. I know you guys could laugh, but, this is, I don't have the audience. All right, now, make it patient-centered. Make it patient-centered. This is a very difficult relationship to be in. If you've ever been a patient in a doctor's office with your primary care provider, the locus of control is not necessarily with you. Okay? Think about where you are in that examining room. And you defer to the physician because he or she has the knowledge and the skills and the authority to ideally make you better, make you healthier with it. And the Institute of Medicine said, well, this relationship ought to be a little bit more patient-centered. We ought to have some say in what's happening, okay? And then the Institute of Medicine goes further in terms of the delivery of care. Make it timely, okay? Make it timely. You are going to wait. People do wait for things, and that's natural to any system, okay? But look for ways to improve the waiting time experience, okay? Make it efficient, and for people who study health economics, this is a really, really big deal. For people who study systems engineering in healthcare, this is a really, really big deal. When we look at true process improvement in health services delivery, we talk about this in the context of Lean, or we talk about this in the context of Six Sigma, where it says, find ways to avoid waste, okay? Waste of equipment, waste of supplies, waste of ideas, waste of energy with it. Find better ways to do that. And finally, make it equitable. The whole field of health services research is really centered around this idea of equitable care. So why do older people have different healthcare outcomes than younger people? Why does geography matter? Why does income matter? Why does ethnicity matter? Why does gender matter with it? And the Institute of Medicine said, well, within reason, it shouldn't. You should get care that is appropriate regardless of personal characteristics. You know, that's incredibly important to us. Now, the systems view, okay? So a little bit of engineering, okay? How things work and how we view health. How we're learning how to view healthcare through a systems view. And it's essentially three parts. There's inputs, there's transformations, and there's outputs. If you've ever done a recipe, if you've ever baked cookies, okay? If you've ever made cocktails, okay? All of those are based upon a systems view. Okay, you start with inputs, and very typical, very generic views of inputs are, you know, who are your employees? What kind of materials do you have? What kind of machines do you have? What is the management or the leadership of the organization? What kind of capital can you draw upon? And more recently is, what information do you have that can be brought to bear? These become your inputs in some sort of bundled process. They make a transformation. They turn inputs into appropriately enough outputs, okay? And that translates into our delivery of healthcare. And we think of it kind of linearly. You go from inputs to a transformation process to an output, but along the way, we can also learn from this, okay? And we learn from this through feedback. Did we do the right thing, okay? If we did the right thing, we ought to repeat it. If we didn't do the right thing, then we shouldn't do it, okay? You know, sort of the classic example is, how many times do you put your hand into a campfire? Generally once, right? Or not even once. And that's the last time you'll do that, okay? So feedback's really, really, really important, okay? The same thing is when we're learning how to ride a bike, okay? It's a transformation process that happens for us to get better and better at it, and we learn more and more from it. The challenge for a lot of organizations is that ability to learn and to continue to be better with it. Now, related to this idea of the systems view, a very classic work in the area of understanding systems is work by Senge back in 1990. And this fellow was the first to try to look at systems and helping us describe systems from not an engineering point of view, but from a management or a leadership point of view, okay? And it put it very, this concept of a system forward very deliberately, and he said, look, you know, every system is to produce an outcome. If it doesn't produce an outcome, it shouldn't exist. And so be very careful of this within organizations. Do things exist because they exist, or things exist because they're supposed to do something? Now, what we want within our health systems is that they ought to do something, okay? The second thing he pulled upon is this idea that no system is completely stable, okay, unless you're keeping horses. Okay. Each system is going to be controlled by feedback. And he says feedback influences things. Feedback influences things. So if you're ever looking for yet another thing to read, if you have time on your hands, his book, The Fifth Discipline, is an absolutely wonderful read. Now, I know what you were thinking is that, is there going to be any tests? And actually,
no.
No tests, but there is a test. There's a
Yes.
small multiple choice question on the next page, on this slide. Okay, there's no answer to this. Well, there is a right answer to this. The fellow that we're looking for is Walter Shewhart in the middle, and he's the old guy in black and white at the bottom. Okay, now, a little bit about Walter Shewhart. Why is he important? Well, again, we're talking about patient safety, and Walter Shewhart is considered generally the grandfather of the quality revolution. Okay, he's the first one that really started about saying, how do we make things better? And initially he did this in the context of manufacturing. How do we make manufacturing better? So he started out at Western Electric. Later he was employed at American Telephone and Telegraph, so AT&T. And way back in 1924, almost 100 years ago, okay, if you've ever seen statistical process control charts as part of a quality improvement endeavor or quality improvement project, he did, and he was the responsible for statistical process control charts. He also talked about this idea of common cause versus assignable cause variation. And so he says, as most systems, common cause variation is okay, and we don't worry about it. And we as decision makers or managers or leaders shouldn't worry about common cause variation in the short term. He said, assignable cause, yeah, that's a big deal. Okay? The way to think about those is we're walking through the bakery at H-E-B, and we're looking at the wonderfully delicious and appropriately baked loaves of bread. For the most part, they'll look the same. They'll be 16-ounce loaves of crunchy Italian bread. They'll look wonderful. That's common cause. We like that, okay? When we see assignable cause, there might be things like maybe one of the loaves of bread is a briquette because the oven was on too high and it burnt to a crisp. Or maybe the oven wasn't turned on and it's just a lump of dough. So then we have assignable cause, and we need to investigate the assignable cause. We need to know why these things happen. So if we think about the example from Vanderbilt where we did the wrong site surgery, well, the assignable cause is there. We can find out a way why this happened, okay? And then he also postulated for us, look, you know, as an engineer, we want to take a scientific approach to things. So he says, we're going to do plan, do, check, act, PDCA, or sometimes it's known as PDFA. With it. And it's simply a way of us being rigorous in how we do process improvement. Now, his scientific basis for control, and so his work, his seminal work in the middle of this is a book that he wrote back in the 1930s, okay? Economic Control of Quality of Manufactured Product, okay? And that one, I would say I'm not going to recommend you guys read it, okay? It's okay. But there's a couple of big takeaways in this. One is his idea of what is a stable, predictable performance versus what is an unstable, unpredictable performance. So scenario one in the upper left-hand corner, that's what we want. That's what we want to see from our processes. We want to be predictable. Doesn't necessarily mean everything is the same, but rather that there is little variation that is exhibited. When there's a lot of variation that happens, there is nothing we can do to it. We just have to work it to a place where it will eventually become stable and predictable, okay? On the right-hand side of this slide, this is an image taken from his book, and what he's talking about in this is paying attention to what we do. And the little piles of, looks like piles of sand off to the right-hand side of the screen there is the defective material. And thinking about what he was doing back in the 1920s and the 1930s and working for AT&T, is they're building phones. Imagine that. They built phones, and they built phones in the United States, okay? And you couldn't look at cat videos on them either. You actually just had numbers to work with. But he said along the way, you start with these raw materials, and they become parts, and they become parts, and they become partial assemblies, and they finally become the finished product. And he said, if you're paying attention to what you're doing, and you're doing it right, you're going to reduce that pile of sand, those pile of defective materials off on the right-hand side if you're paying attention to what you're doing. Because you're going to be predictable, you're going to be stable, you're going to be efficient, you're going to be effective. And so in a way, if this kind of sounds like the Institute of Medicine's 6 aims, it actually is. The history of this stuff is about 100 years old, and we tend to draw upon themes that work really, really well, okay? Now, Shewhart did this, but it took a while for healthcare to figure this out, okay? And back in 1966, a fellow by the name of Avedis Donabedian said, well, when we look at healthcare, when you think about healthcare in the 1960s, most of us would have had a primary care doctor. It probably would have been a man, and he may provide house calls to us and actually show up at our house. And if we ever got sick, we might go to his office, and he would share this office with a receptionist and maybe a couple of nurses. And if we got really, really sick, we would go to hospitals, and we'd spend a considerable amount of time in hospitals getting better. And he said, well, here's an opportunity for us to truly study how healthcare is delivered. And Don Abedian postulated, the way we look at this, and sort of a nod to Schuchart, is there's a structure, there's a process, and there's an outcome that we can talk about for every time we provide healthcare. And structure was easy. Structure is basically an inventory. What do you got? Okay? So if you picked up the annual American Hospital Association's Guide to Hospitals, and you said, well, what services do you provide? How many beds do you have? Are you part of a system? And so on and so forth. That's structure. And Don Abedian said, that's really nice because it's an inventory with it. He said, what's more important is what is the process of care? And so we think about Schuchart and coming up with predictable processes where we do the same thing or the similar thing over and over again with little variation. And again, thinking back in terms of the mistake that happened at Vanderbilt, the process is important with it. The process is important. It's not a cottage industry. And we know there are certain things that we do really, really, really well. And we know that there are providers out there that if they do similar processes over and over and over again, they get really, really good at it, like solid organ transplants, like knee replacements, even flu shots. And if we watch nurse aides who deliver flu shots, I mean, they've done it over and over and over again. They're really, really good at it, okay? And the one that took a long time, and by that I mean several decades for us to actually think about in terms of health services, is the idea of outcomes. Where do we report the outcomes of care? And you can start thinking back towards the Office of the Inspector General report that talks about, systems aren't built to record things that happen bad to our patients with it, but outcomes are equally important. And Don Abedian talked about this in 1966. He said, tell us about recovery. So after surgery, after illness, tell me about restoration of function. So you can think about like an athletic injury or a organ transplant or an amputation or an accident. We can talk about survival of the patients after procedure, say, for example, cancer treatment. And then we can also talk about patient satisfaction. So if you've ever been an inpatient at the time your hospital where the services were provided is going to be surveyed by CMS, the Centers for Medicare and Medicaid Services, they may give you the HCAP survey and ask you as part of their components, how was care provided? What's your opinion of the care that was provided to you? But Don Abedian put this in 1966, so, a long time ago. Said for us to do this, though, he said we have to come up with criteria and standards. He said, so how do we know we have a good structure and a good process and a good outcome? Well, we have to define criteria. And the criteria says, well, what characteristics ought you have? And then once you've described these characteristics, what's the standard that tells us that it has been met? Okay, so again, this kind of brings back to that very first definition of quality where we say, how do we meet or exceed customer expectations? Well, to articulate this, we set up criteria, and then within the criteria, we say, this is the standard we ought to be able to attain. So, for example, on the next slide, in this particular table, I'll show you, here's an example that illustrates what is a structure, what is a process, what is an outcome, the focus of the assessment, what might be the criterion, and then what might be the standard that we would hold it to, okay? So if we look at structure, we could say, well, primary care, group practice, family and internal medicine, and our criterion is, look, all the docs that we have working for us or part of this practice ought to be board certified, either internal or family medicine, and our standard is everybody, so 100%, okay? If it's a process, we could borrow from the Joint Commission and what was called, way back when, was called the ORIX performance measures, and they said, so tell us about the treatment of patients hospitalized for a heart attack. And we know, because there's very good clinical evidence out there that says after, post-heart attack patients get beta blockers on discharge from the hospital, okay? And our standard might be, well, 96%, okay? We'd like 96% of 96 of every 100 ought to have received a beta blocker prescription, okay? And then if we look solely on outcomes, and we take, again, a different patient population group, the blood pressure of a patient with diabetes, we'd say, look, if you're a diabetic patient, we'd like you to have a near normal blood pressure of 130/85, okay? And we'll work with them. We'll do diet counseling. We'll do exercise counseling. We may provide medications if as part of that as well. We'd say, what our standard here for our particular patient catchment, we want 50% of them to have a blood pressure at or below 130/85. And so this gives you a sense of, as we move from this idea, which is kind of a vague idea of patient safety or patient quality, how do we actually articulate this? How does it actually become part of our delivery of care that we have? And it's this notion of moving from structure, process, outcomes to actually establishing criteria and establishing standards. Now, what's the process on this image here, these two images here? These are important, okay, because we see these all the time. It's part of our daily life. So on the left-hand side, this is a card reader to get us into an office building. And if you notice, the door is open. His door is kept ajar. When is a door not a door? When it's ajar.
Yeah.
Okay. So the card reader didn't work, so we found a way around it. So we stuff an envelope in it to circumvent the process. That's not good, okay, for a whole bunch of reasons. The other one, which I think is absolutely wonderful, this is from a parking structure in Santa Monica, California, but it's becoming more and more commonplace, is if you look in the ceiling, you will see green lights and you will see red lights. And one of the perennial issues that people have when they come into a parking structure is, where's an open place to park my car? Well, they said, well, let's put green lights and red lights there. And if it's a green light, there's an open space. If it's a red light, it's occupied by a car, so I know which rows to go down. Absolutely wonderful. And it took us years to develop this. So processes are really, really important. So what we look for is, how do we mistake-proof the processes? I know what you're thinking. Why is there Big Mac in the upper right-hand corner? Okay, and you're thinking, well, this is over the lunch, and I'm thinking about food, and we get to this point, and Cassidy said she'd bring us lunch, but, never mind. So the Big Mac actually describes for the customer what the process is to build a Big Mac. For those of you who are old enough, you would know the Big Mac jingle. 2 all-beef patties, special sauce, lettuce, cheese, pickles, onions on a sesame seed bun. That's the process. That also trains the McDonald's workers. So you know you're getting a Big Mac, you're not getting chicken McNuggets, and you're certainly not getting a Whopper, okay? So we want to mistake-proof processes. The question we ask ourselves is, why do the mistakes happen in the first place? Well, first and foremost, we forget. We simply forget. And we forget because we may not be trained to do this, okay? We look for ways to embed that training. So Smokey the Bear tells us, only you can prevent forest fires, okay? Stop, drop, and roll, very straightforward, very easy to remember things that we ought to do that reinforce it. Healthcare is not quite that simple. It's complex. So forgetfulness can happen. We may not understand how things work, okay? Or we may not be able to identify it because we're not familiar with the process. So it takes some time to learn this. We simply may not have experience. We didn't know we should do it this way. Or we have so much on our plate that we lose attention or we don't pay attention. And this is particularly the case. They found this out as robotics are becoming more and more commonplace in the manufacturing industry, that when the process is automated, we tend to zone out and we tend to forget things with it. So we said, all right, if we understand how mistakes happen, let's find out a way to prevent them. And from the Japanese, we have an approach called poka-yoke, okay? So if you're partial to soft-boiled eggs in the morning, of course you poka-yoke. But this is separate, and I digress. All right, so poka-yoke, some examples. Little pictures in the top part of this slide. Okay, fuel gauge on a car. It's telling us 2 things. 1, we ought to go to the gas station, and 2, more important is the little triangle on its side next to the fuel pump. This is really, really important because it tells us which side of the car do we have the fuel filler on, which side of the car do we actually have to put next to the pump so that we can actually put gas in the car, okay? Now, the next 2, One says look left, the other one says look right. So it's telling advice for pedestrians. Which way should you look for oncoming traffic? Okay. One of them is a picture that I took when I was in London, England. Okay, appropriate enough because they drive on the opposite side of the street. The other one was in Albuquerque, New Mexico, around very near Route 66 for the same reason. Not that they had, the North American tourists would know, they would know how traffic would work, but they said, well, if you have tourists from other parts of the country or other parts of the world, predominantly European tourists, they may not know which way to look in the face of oncoming traffic. So each of them sort of preemptively said, let's try to mistake-proof things, okay? Now, when we take these approaches, this is wonderful because we're looking at this and we're saying, how might mistakes happen? And when we do Poka-Yolks, it's based upon a prediction. We know something is going to happen, or we know something that might happen, and we try to prevent it, okay? And if we can't predict it, then we try to detect it. And we say, oh, it happened. So why did it happen? And we try to find a way to stop it from happening in the process, okay? So those are Poka-Yolks. Now, there's lots of examples of Poka-Yolks. On the next slide, we have a nice valve up top that says if the valve is parallel to the pipe, everything flows through fine, and if it's perpendicular, it doesn't. Okay, so the nice little red brass valve at the top. And so examples here from industry and from the manufacturing industry, from service industries, you see things that they're designed so that we don't want to make mistakes, or that it's really hard for us to make mistakes. Things have to be in the correct position. There are sounds or lights that tell us if we're doing things appropriately. So, for example, on your laptop, on your PC, one of the things that has come up and has sort of been drilled into us, the moment we try to close out of a file, it says, do you want to save this? And then they say, are you sure you want to exit without saving this? Okay. We also ask you to repeat your passwords. Okay. Just because it's harder to remember the first time, try to repeat it a second time. We do airplane maintenance. We have parts that have to be fit in the correct piece. And then if you've ever ordered anything from Amazon, and if not from Amazon, if you've done the self-checkouts at H-E-B or at Kroger, the scales are set up to weigh things based upon what you've scanned and what you're putting in the bag or what you're putting in the box. And these things should match up, okay? And they maybe even compare it to a picture and say, if this is what you've ordered and this is what it weighs and this is what it looks like, does everything match up to say we've got the correct things, okay? And so those are wonderful examples of Poka-Yolks that we can borrow from, okay? Now, fitting this into healthcare, fitting all of this stuff into healthcare. So we think about all of the opportunities, all of the touch points that we have in the delivery of care. And we start on this, if you look at around, say, the 2 o'clock part of this, if we think about this as a clock, around the time of an assessment of a patient. And we say, all right, a patient has come in, he or she is presenting with certain conditions. We need to find out what's going on here. And it may be a combination of things that come in to help determine our assessment. We have the patient and his or her family. We may bring in a colleague. We may have diagnostic findings, and we may have physical findings that present our assessment. We bring this all together and make a decision. What should we do? Okay, what is necessary for us to do? And this becomes the intervention. This integration of data forms to us the intervention that says what interventions ought we do, what kind of outcomes could happen, are there physician inputs and orders that are needed or as necessary, and we perform this, and then we do a reassessment. In a way, if you think about this, this is very similar to Schuhart's Plan, Do, Check, Act. We're doing very much the same thing, and we get the reassessment to see if we're going down the right way. Now, from the Joint Commission, it says, this is great. We want to deliver care. We want to do no harm. We want safe and appropriate care for our patients if we're following the Institute of Medicine. So the National Patient Safety Goals from the Joint Commission, and this was released just last year. They update it periodically. They said, look, identify the patients correctly. Seems pretty straightforward. Identify the patients correctly. We should be able to do this. But if you've ever had and you've ever ordered pizza, did they get your name right? Did they get your order right? Most of the time, okay? And we're way more complicated than ordering pizza. So make sure the patients are identified correctly. Improve communication. I can't stress how important that is. How do we share information about the patient and his or her condition? How do we communicate between between shift changes? How do we communicate between providers? How do we communicate with their family members and their loved ones? Okay? So communication is important. Use the medicines safely. Gets back to identifying the right medications and the appropriate medications. Use alarms safely. We don't want to be the ones who cry wolf. So when an alarm goes off, it ought to be an appropriate alarm that requires us to take action. Prevent infection. You know what they tell us? We ought to wash our hands. We ought to sterilize our equipment. We ought to wear personal protective equipment. Okay? So prevent infection where possible. Identify patient safety risks, you know, based upon age, based upon ethnicity, based upon demographic or physical characteristics. What might be their safety risks that they occur? And then, you know, a nod to Vanderbilt, prevent mistakes in surgery, okay, to the Vanderbilt example. Now, when we take these national patient safety goals and we say, well, how might this work within an organization? We talk about it as the scope and use of patient safety considerations, and sort of three big buckets here within any organization. There's going to be teamwork, okay? This is important to any aspect of process improvement. There has to be teamwork. So how do we work together? How do we value each team member and his or her contribution, and worry about culture, okay? We don't like doing things differently. We don't like doing things differently, especially if we haven't been involved in doing things differently. And so culture may make us resistant to change, resistant to doing things better. So it's not just teamwork. We also have leadership. So the leadership of the organization, so it starts at the top with the chief executive officer and his or her board members, and they have to have stake in this. It's got to be consistent and sustained. You can't be willy-nilly in this. I think this may be the first webinar where we've said willy-nilly with it. We have to be consistent in terms of how we deliver care and how we do patient safety considerations. Be careful of fear, punishment, and reward with it. What we talk about from quality is the idea of intrinsic versus extrinsic motivation. Extrinsic motivation, we just give people more money, and we hope they do things better with it. Intrinsic motivation is a sense of pride in the work that they do. And so there is a balance there between making people scared of what they're doing and rewarding them for what they're doing. And behind that, too, culture comes back, is equally important, because if the culture of the organization isn't supportive of this, it's not going to happen. It just won't happen. And then finally, and this is something that's been working for probably, I would say, maybe 20 years or so, is sort of an acknowledgement that within the delivery of care, not just within the United States, but internationally, is that we're going to admit when we make a mistake. Okay? So when adverse events happen, disclose it, admit it, and take responsibility. Okay? And share that with patients and families. And what they found is that the apology from the providers can go a long way to ameliorate the patients and their loved ones' concerns about it. But that was a cultural change. So how do we get better? Well, we can learn from high reliability organizations. There's a wonderful report a couple of years back from the Institute of Healthcare Improvement. It said, look, you want to be better. You want to be almost perfect in what you do. Go to industries that are almost perfect. So aviation, air traffic control, nuclear power plants, all great examples. If we think about how many people travel and where they travel every day with all the airlines, with all the airports, with all the baggage, and more often than not, everything is safe, okay? Everybody gets there and their bags get there. Similarly with nuclear power plants, you know, we don't think of those as having accidents very common. They're rare events with it. And they said for organizations to get to this point, they follow this evolution. We think about quality control, where we just behave better as a system. We go to quality improvement and we try to anticipate what might happen and if you will, get the jump on it. And then when we're really good at this, we're mature as an organization, and it's part of our culture that says we're going to be a high-performance organization, and we're going to say we're going to be proactive in the way we provide care. Now, last part for us this afternoon is, well, what sort of a tool that would help me be good at this as an organization, and something called failure modes and effects analysis. And this has been around, again, the tools aren't new. They've been around for a while. This has been around since the late 1950s, early 1960s. And failure modes and effects analysis is really us asking questions about a process that we do, a product that we manufacture, a service that we deliver. Just tell us the steps in the process. Tell us what could go wrong. Tell us why the failure would happen, and what are the consequences of failures, okay? And we think about these, we say, all right, what could go wrong? Why would the failure happen? And what are the consequences of each? We go one step further, and then we say, if these things happen, what is their likelihood of occurrence? You know, how often would it happen? What is the likelihood of detection? We would find out that we made a mistake, okay? And if a mistake happens, if a failure happens, what's its severity, okay? This is, in a way, very similar to how CMS used to evaluate nursing homes under the old OSCAR databases, where they'd go to the nursing homes and they say, let's give us scope and severity of the deficiencies that we found when we surveyed the nursing homes. So in a way, it's very similar to this. And it's a very thoughtful, very rigorous approach to looking at a process, okay? On the next couple of slides, I've got an example of what failure modes and effects analysis would look like in healthcare. So the first one here, this first slide here, talks about likelihood of occurrence, likelihood of detection, and severity. And so in this table, the severity rating, and you are not obligated to use this scale at all. You can develop your own for your own organization, for your own processes. It's a 1 to 10 scale, okay, where 1 means very minimal impact on the patient. Patient probably would not notice, to 10 being would seriously harm the patient. The likelihood of detection, also similarly on a 1 to 10 scale, from very, very unlikely to be detected to very, very high likely of being detected, okay? And then the occurrence rating on a similar 1 to 10 point scale, where 1 represents an almost certain occurrence to an almost impossible occurrence. And then it's your responsibility as owners of processes within health systems to decide which of these applies to each step of the process. So on the next slide, this is a fictitious example of a specimen collection process where, and I apologize for the size of this because it's not intended to be testing your eyes at the same time, but it gives you a sense of how we would work the process through the various opportunities for failure, how we would evaluate each of the opportunities for failure, and what we would do to try to mitigate the failures, and who might be the responsible parties for each step of the process. And it gives us this collective sense of, all right, if things go bad, how might things go bad? Who would be responsible? How would we prevent things? How would we prevent bad things from happening? How would we prevent failures from happening? So, bringing things together, some parting thoughts on it. How do we design safe processes? And so some guidelines here for us. People do stuff. They do stuff, not just in healthcare, but everywhere. So bring in human factors knowledge into trainings and procedures to understand what people do and why they do what they do, okay? If you have the luxury and the opportunity, take advantage of technology and procedures with a focus on the end users and with particular a focus on, well, what happens if it goes wrong? And you can see this in some sense if you work with electronic health records, where they set up the technology kind of based upon where people are looking on the screen and how they go from one field to the next field to the next field to the next field to enter in data with it. And so try to think about who's actually going to be using what you're providing. Where possible, reduce the complexity. More steps, more handoffs is just more opportunities for failures to happen with it. Think about when you fill up your car with gas. When you're at the gas station and you pay at the pump, the steps there are very logical, very ordered appropriately with it, and with an intent to reduce complexity, similar to how we use ATMs with it. So try to reduce the steps. Make sure safety initiatives address prevention, detection, and mitigation. Don't ignore any of these components. Try to prevent it. If you can't prevent it, you detect it. If you detect it, can you mitigate it? So try to catch it ahead of time, if you will, okay? The last 4 to consider, standardize things. If we think about in terms of quality and process improvement, the idea of lean and lean systems that try to drive out waste, standardization is really, really important. We standardize processes. So for the longest time, McDonald's had a very, very standardized process. You could get everything the way McDonald's wanted you to have it. And in part, this is why Burger King talked about you could have it your way. Because they said, well, let the customer decide how he or she wants their meal with it. But a standardized process for us can be very, very, very efficient. So think about processes, tools, and technology and equipment, okay? Label. Label is incredibly important. Tell us who it is, what's it for, how we do this. We're seeing a lot of the pharmacies now taking advantage of this, where they color key the bottles, they color key the labels, they change the font. They tell you what your medication works well with, and we tell us what your medication might work against with, especially if you have several medications that you're taking, when you're supposed to take it, how you're supposed to take it, how often you're supposed to take it, okay? So make sure you do that. Use barcoding. Barcoding has been around now for almost 50 years as a technology. It seems amazing in that respect, but it's something that is easy to label and keep track of things through barcoding, okay? And finally, the last bit of advice here, we think about, again, our purpose to provide right care at the right time, at the right place for the right person, okay? Make things difficult that should be difficult. You know, that seems kind of like trite advice. But in terms of improving the process of care, if it's difficult to do, it's difficult to do. The easy stuff should be easy with it. And I thank you for your time. I will open it up for questions.
Great, thank you. Let's see. If you have a question, you can type it into the chat box for everyone to see. You can send it privately to me, or we can probably unmute you and you can ask Dr. Cote your question in person. Let's see. Can we unmute the participants? Okay. Yeah, it looks like we would have to one by one unmute you, but I can do that. But in the meantime, if you have a question, please feel free to type something in the chat box. And while we're giving you a few minutes to collect your thoughts, I will go ahead and tell you that we will send the slides out after this call, as well as a really quick survey. It's about 60 seconds, so we would appreciate you just taking one quick minute to complete that survey. Just give us your thoughts on the presentation, any feedback that you have, or anything you might like to see in an upcoming presentation. Okay, we actually do have a question that was sent privately in the chat. Where can we read more about human factors?
Cassidy, can I send you a list of resources?
Absolutely.
For human? Let me do that.
Absolutely.
Off the top of my head, I have a list of things that I would recommend in terms of human factors research, ranging all the way from textbooks to research articles. So I'll look for something that is approachable with it, and I will send a list of human factors articles and references for Cassidy. And if she could, she will share it with the audience members of the studio audience. Thank you.
I would be happy to. So we can send those.
We can do that.
Yeah, we can send those.
Then you also don't have to type it down, too, which is Pokeyokes in action. So you already know what the reference is.
Perfect. So we'll send that out to you in the email that follows this call. Okay, well, just out of respect for your time, because it's a couple of minutes after 1, and I don't see any other questions right now, we will go ahead and wrap up. But let me go ahead and mention the website again in case you're interested in keeping an eye out for the open portal on September the 3rd, or if you want to check out past webinars or register for future webinars, it's www.optimizingruralhealth.org, and we'll link it out in the email webinar. So thanks for attending, everyone. We appreciate it. We appreciate your time. Thank you, Dr. Cote, for joining us.
You're more than welcome.
Great.
Thank you, folks.
Thanks. Bye.
Take care. Bye now.
You getting all your problems fixed? You're just creating more? Why did that start happening?